good morning and good afternoon. I'm sorry, my micro was off. It's a pleasure to welcome you once again for IWC Clinical Case Symposium. We are very happy to see that more and more are interested in our webinar, and we would like to thank you. Today, we will have two cases, one from Roma with Biagio, ABATE, and Lucian MARCOVICI, and the other one from Paris. So once again, thank you to all the panelists for joining. And we will be moderating this session with Gustavo Gomez and Lucian today. So we will start right now with the first case from Italy with Biagio and Lucian. The case very interesting about arthroscopic lunate excision in Kienboch disease. And so Biagio, if you are ready, please could you share your screen, please?
Yes.
Hi, Lorenzo. Hi, Gustavo. Hey. So,
I'm ready.
Yeah, ready. Perfect. So to everyone, don't forget to post your question and comments on the chat. And we have Gustavo and Lucian that will manage the question. Is okay, Biagio?
Yes.
Okay, so we are hearing you.
First of all, I would like to thank Dr. Lucian MARCOVICI and Alessia Pagnotta for this opportunity, and sorry for my not English, good English.
It's perfect.
So in this case, we speak
sorry,
about
Biagio, we don't really see your screen for the moment.
Share the screen.
What?
Condividi lo schermo.
Lo condivido.
Maybe it will be fine. You know why?
Just a moment.
Take your time. No worries.
Now?
It is perfect. Thank you.
Okay. Thank you. So, okay. I speak about, in this case, a girl of 15 years old, and she was diagnosed Kienboch disease, her right dominant wrist, when she was 14 at Other Hand Surgery Center, and she was classified like 3A according to Lichtman classification, and she underwent to conservative treatment with immobilization for 6 weeks and pulsed electromagnetic field therapy for 3 months, and she was followed up for 1 year. So she doesn't practice sports and low demanding patient. The first 2 questions are: what is your protocol for non-surgical treatment in Kienboch? And don't you think it's better to do surgery when you see condition getting worse, even in young people?
So
those are 2 questions we are doing for the panelists.
Yes, for the panelists.
Okay.
Ideo, you want to answer about it? You have a great experience in Kienboch disease.
And Lorenzo wanted to talk as well, but it's okay.
Okay.
I can go after. It's okay. I can go after.
Okay.
Ideo?
Okay, can I answer? So this is so young patient, 15-year-old girl, and maybe this conservative treatment is not effective. So That's why the surgical treatment is required. But in this case, I recommend the radius, shortening of a radius for is best indication for this case, I think.
Okay.
You don't have a IDEO in your experience with in your team. You don't have a limit of age for surgery, or are you do you more indicate the orthopedic treatment in young patients?
Yes, in young patients, even in the Rickman 3A, is segmentation has occurred. But maybe some years ago, maybe 10 years ago, my senior published a paper for JHS, Journal of Hand Surgery, for Kienboch disease, Rickman 3A in young patient. They performed radius shortening. Just not radius shortening or STT contemporary fusion was effective. We reported at that publication.
So your answer is yes. You think it's better to do surgery in young people, right?
Yes, young people.
Okay,
right.
okay, perfect. Lorenzo, you wanted to speak?
Yeah, same thing. I think especially in young people, it's better to prevent any worsening in time, because it's been published that pediatric forms have a good prognosis, and elderly people are also usually good functional results with Kienboch disease. But when you're at the end of puberty and when you're reaching adult age, even with young adults, then your Kienboch is going to be an evolutive pattern, and I think conservative treatment is to be tried for a few months, but as soon as you see any worsening, then you should go to surgery quickly to prevent any worsening, because if you get if you get fragmented lunate or even worse arthritis at like 17 or 80 years old, then it's a disaster. So I agree. I think you should be quite aggressive with Kienboch disease when it's worsening over time.
But what I can see, thank you, Lorenzo, what I can see here is that the follow-up was made every 3 months with a new evaluation. So normally they should have seen that there was a quick worsening of the situation. So what is your protocol? MRI, it is a clinical assessment every 2 months, and MRI every 6 months. Someone would like to give his opinion about this? How to assess this young patient? I can see maybe Fabio, Ideo, Lucian, Gustavo, Lorenzo.
I do. When I have a Kienboch disease under medical surveillance with no surgical plan, I do MRI every 6 months actually.
MRI every 6 months for Lorenzo. Perfect. Thank you.
We also agree in our center, if it doesn't go better, we do surgery. We prefer to do vascularized bone graft in these cases. We use the 4-5. But we totally agree with the aggressivity in young patients. Okay, so go on, Biagio.
Okay.
Sorry, may I ask? I don't have any comments, but I have a question for for everyone. I was just wondering, like in your experience of Kienboch disease, right? I'm sure all of you guys have seen a lot of patients with this. I personally haven't seen a lot, but how many percentage of these patients are symptomatic? And even if they are asymptomatic, and if you see radiologically that the Kienboch is getting worse, you would still treat it?
It's a hard question because a lot of asymptomatic patients, well, you don't see them in consultation.
I don't see them also
because they don't know they have a Kienboch. So
So I assume that most of the patients that comes to your clinic, they are all symptomatic patients.
Yeah.
Yes.
Sometimes we have this discussion when we have we are treating a side, and we do a systematic MRI because the patient has sometimes a pain, and we see the same situation on the other side. So the question therein is, do we perform a prophylactic treatment for this patient? Radial shortening, even if they are not really symptomatic? It is a hard question because we treat only symptomatic patients normally.
Okay, thank you.
Go on, Biagio.
Okay. And she was sent to our center after 1 year at the age of 15, and she hasn't shown any improvement after conservative treatment, and she has a lot of pain, and this is the parameter of first visit, and functional impairment. So we evaluated the X-ray with the Hume index and the radioscaphoidal angle, and MRI, where we can see the poor vascularization of the bone of the lunate. We can see the carpal collapse, and then the fragmentation of the lunate and the flexion of the scaphoid. So after only 1 year, she was worse than initial condition, and she was classified like 3B stage according to Lichtman classification. So do you need other exam procedures for staging treatment decision? And do you consider arthroscopy evaluation critical for treatment decision?
I would maybe, if I can do a quick comment, can you go back one slide on the,
yes,
on the Lichtman classification? Because this is something we often talk about, is the Lichtman classification. It's been changed in a few years ago to add the 3C stage, which is the stage where you have a fragmented lunate. But actually, in the other conditions to be a 3C is when you have already a failure of the radial column with the flex scaphoid. But actually, you have some patients where you have fragmented lunate with a good radial column, and those patients are not classified by the Lichtman classification. And this is something, I think lunate fragmentation is actually more frequent than we think. And that's why I always do for every patient MRI and CT scan for wrist evaluation, because the MRI is not always very good on the fragmentation, whereas the CT scan is. And sometimes you have a surprise. You have like a good radial column with no flexion of the scaphoid and a fragmented lunate. And this is something where you can quite treat well the patient with some techniques. But in my opinion, you have to be careful with the Lichtman classification, especially regarding for lunate fragmentation.
I totally agree with Lorenzo, but yes, I totally agree. Sometimes the MRI underestimate the 3C stage, and I think we are going too fast for your case, Biagio, but the arthroscopic evaluation will be is mandatory in those cases, I think, for the therapeutic options. Yeah, thank you.
Do you use the arthroscopic classification, Lorenzo? For example, is useful for you the
Bain classification?
Arthroscopic yeah, exactly.
I do. When I try to classify every Kienboch patient, I actually do this threefold new IFSH classification with the Lichtman classification, what you can see on the X-ray, the Schmidt classification for the MRI, and the Bain classification for the cartilage evaluation arthroscopically. And that's, I think it's a bit constraining because you have to do a whole lot of examination and so, but I think this is the best way to assess every case for every patient. and choose the most accurate treatment.
Great.
I personally totally agree with you, Lorenzo. All the exams give you something, a small point, and especially in young patients, it can make the difference. You know, to have a lot of data to decide with them what is the best option, because in the end you need to decide with them and with the family. Close. I asked the other panelists to close the audio because we.
It's okay.
Okay. So Biagio, you want to go on?
Okay. So we always do an arthroscopy diagnostic to value the in radiocarpal joint and mid-carpal joint. And here in radiocarpal joint, we can see synovitis and radial stylocartilage damage with a good lunate and scaphoid fossa. So we can see a chondromalacia lunate with a not good bone. And in the metacarpal joint, we can see chondral defect capitated. It is important because the bearing zone is good. So it's important to classify according to Bain classification, and we can see the fragmentation of the lunate. So the classification of Bain, we classified like 2B stage, and we use this scheme to help us to choose the most correct treatment, and is based on age of the patient, bone of the lunate, and carpus. So in this case, we can see an unreconstructible vein with a carpal instability, and we spoken with the family about all treatment possible in this case, and family and the patients asked to us a mini-invasive treatment. So we discussed, and we say that we have two kind of different treatment possible, or a bone graft, vascularized bone graft, or arthroscopy lunectomy, but we can see the not good quality of the bone, and so we opted for a lunectomy in this case. So with a minimal invasion and no bridge barn for future treatment. And this is some frame of surgical procedures. We can see in the radiocarpal joint the lunate, and we remove it with shaver and with the grasp bone, and it's possible because the quality of the bone is poor. So we remove all the lunate, leave small pieces attached to the volar and to the dorsal capsule to not damage it. Then we take off the traction to see the position of the capitate and the stability of the proximal row. And we can see it also in X-ray dynamic. This is lateral view. And this is the X-ray after the treatment. Then we make an ultrasound session after 1 month to see the collocation of the capitate between triqueterum and scaphoid and a well-represented dorsal capsule. And this is the patients after 2 months. No pain and a good ROM, range of motion. So Blanco speaks about in the papers open technique or open approach to remove the lunate, and he showed 4 cases with a long follow-up till 43 years, and these cases show readaptation of the joint surface and rearrangement of the remnant carpal bones after long-term follow-up. So clinical results were good. And Onishi speaks about a biomechanical comparison between arthroscopic and open lunate, and he said to us that if we don't lesion the extrinsic ligaments, the kinematic of the proximal carpal under axial loading is very good. In the 2021, Shimizu show us the same technique with a follow-up of 2 years, and we can see an excellent postoperative pain relief and functional recovery, but he paid attention on a possible stylotriquetral conflict in patients with neutral or plus ulna, but in this case, we can see with diagnostic arthroscopy, and we can do a styloidectomy always with arthroscopy. In this year at the FESH, Lorenzo Merliani for the first time show his results about the same technique, but in a young patient, the average age is 27 with a follow-up of 3 years with a good results. So at the end, the take-home message is arthroscopy is a critical for decision-making in Kienboch disease. There are a lot of treatment proposed in the literature for any single stage, and treatment should be personalized on patients' need and expectation. So the arthroscopy lunectomy is safe. We have a ligament preserving, no bridged bar for future treatment, but we haven't a long-term follow-up. So we must study, and we must we needed a long-term follow-up to assure of this technique. Thank you.
Thank you,
Thank
Biagio.
you, Biagio.
Could you just stop sharing your screen, because I would like, before going on with the discussion, just to share the results of the poll, because the attendees were asked for the preferred treatment here, and it's very interesting because 28% of the attendees would choose the vascularized bone graft in this case. We have 11%. 11% the proximal row caprectomy, 17% of the attendees lunate excision plus partial fusion, 17% single lunate excision, and other treatment for 28% of the patients. So we have only 17% of the attendees who would have chosen in this case a single lunate excision. So now I think we can go on with the discussion. Lucien and Gustavo.
Yes.
Has the panelists have any trick to conserve the ligaments of the carpus when we are doing the lunate excision?
It's difficult because the best way to conserve the extrinsic ligament and the capsular attachment is to leave some bony chips, volar and dorsal. but depending on the size of the chips you leave, then you might have, and I did reoperate last week or 2 weeks ago a patient because I think I left too much bone actually, and he had an impingement in extension with the dorsal chip. So I think the main tricks are to do the dynamic examination on the X-ray at the end of the procedure to see if the bony chips you leave are not impinging with the volar or the dorsal structures with inflection extension, and also to perform, if needed, a volar portal to have a good view of your dorsal resection, because it's not easy to have a good clear vision of your dorsal resection with the scope in the 3/4, I mean in the dorsal portal. So it's not easy. The other thing's not easy is actually it's quite a demanding procedure if you're not quite frequent user of wrist arthroscopy, and the main risk is also damaging the head of the capitate or the lunate fossa of the ridges, because then if you do it, then unfortunately you burn your bridge to a future PRC. So I think it's a very good technique in really precise indication. For me, the indication is a fragmented lunate, because I think, in my opinion, patients are mostly painful on the fragmentation, not so much on the rest, and that you're very efficient. And you can see here in your case the post-op results, which are only at 2 months, and the patient is already quite relieved of the pain. And I think it's a really winning surgery on the pain. So the indication is fragmented lunate with a good cartilage elsewhere and a good radial column. And yeah, but it's demanding. I mean, it's not you do not resect a lunate by pleasure. It's you have to choose the right patients and train before it.
Thank you, Lorenzo.
I have just a comment.
Carlos is raising the hand.
Sorry. Yes, sorry, Gustavo. Yes, I'm sorry, but I have just a comment. I never perform actually total lunate excision, always subtotal lunate excision. And I think it was also one of the key points to preserve further stability in the future. So even when we accept this problem of dorsal impingement, even if we perform only subtotal excision, the patients are doing very well. Just 1 week after the surgery, the pain totally disappeared. So it is like a miracle. That is one of my first comments. My other comment is, Lucien, you performed your technique all dorsal. You don't use a volar portal?
In this case, I didn't use it. I left the fragment in the dorsal capsula. It was a small fragment because the lunate was so poor that was, for me, it was easy to take it off. I really took it off very quickly because it was really necrotic. There was nothing inside. Normally, when you do an arthroscopic carpectomy, not in Kienboch, it's not so easy. It's if it's in an osteoarthritis condition like SLAC or SNAC, it's not so easy to take off the bones because they are sclerotic, and it takes you a lot of time, more than you think. In this case, the quality of the bone was so poor that with a bone grasper, we could take easily the bone off. And I prefer to take it with a bone grasper than with a burr or a shaver, because I damage less the other surfaces in this way. But I saw a small fragment that remained in the dorsal capsula, and in the dynamic X-ray in the operation room, like Lorenzo said, it's mandatory. I saw that it doesn't impinge. So it's I also want to thank Lorenzo because he was very helpful for me to with his tips and tricks. He has a great court of patients, so he's very expert with this, and he was helping me to do it easy.
Okay, thanks.
We
Carlos?
have Carlos.
Yeah.
Hello, can you hear me? Can you hear me?
Poorly. Can you raise the volume?
Now, can you hear me?
Yeah, a little bit better.
Well, I will ask two questions to Lorenzo and Lucian and Gustavo. The first one is, did you add any arthrodesis, intercarpal arthrodesis, to this procedure? Is not the another question is not the age of this patient an issue for you? I mean, some of paper about this technique recommend use this technique mainly in older patients. Some papers talk about 65 years old and very low demanding patient. So I would like to know if in your experience, it's not that one problem for you and your patients.
Okay, I will. Before I did surgery, I spoke with the family. I think this is the main issue, to speak with the family, because she is a teenager, so also the family has a great responsibility on the case. So we spoke with the family and we talked about a lot of options. Okay, so they wanted something small for her, you know, they didn't wanted big surgeries. Okay, and this is why I think that the arthroscopic lunectomy was a good surgery for her, because it's something small that doesn't exclude other options in the future. I could have added a scaphocapitate arthrodesis, absolutely, okay, but I can add it also in the future. Okay, it's quite easy to enter the scope, prepare the surfaces and put 2 screws on it. It's nothing big. Okay, but we need to see if we need it. And the thing is that in Kienboch disease, a lot of things are unknown. Okay, so I don't think that we can say that there is a gold standard surgery, you know, and we have a lot of experience with open surgery. Okay, of open lunectomy, but arthroscopy changed the cards on the table, you know. It's different if you open the capsula or if you don't open the capsula. So I took my risk on this case, absolutely, but maybe I'm right or maybe I'm wrong. Time will tell, you know. But I think we need people that do a lot of wrist surgery need to take their risks and give the border the indication, because if we don't do it, nobody will do it. This is my opinion. Okay.
Yeah, absolutely. I think I would have chosen the same technique in this case, because what you have to understand about arthroscopic lunectomy, it's mostly a pain relieving surgery. Actually, it's not something that you want to, you know, reconstruct, or it's just mainly to relieve very, very significant pain due to the lunate fragmentation. And I think it doesn't change anything if you do any fusion or so, because you can always do this later. And the goal is to relieve the patient from his pain, at least from some years and possibly for many, many years, because Kienboch can have also a very slow evolution in some patients, and some patient can wait 10, 20 years to have a collapse of the radial column. And then if you have a collapse of the radial column 20 years later, well, then you do your PRC, you just have the scaphoid and the triquetrum to remove, and you're back to a good functional results. But you've gained 20 years without the PRC. So maybe in 1 year the patient will do bad, and then it's always time to do another surgery. But maybe she will stay good for 30 years. So we don't know. And I think as Aram and Yushan said, you didn't burn any bridges, and it's true for every technique. I mean, what was false 20 years ago is now true, even in knee surgery, shoulder surgery. We have to push the limits and see what's what. But in this kind of situation, we don't take a big risk, actually.
I totally agree with Lorenzo. We did a session about this technique with IDEO and Professor Choé at the last Seasonal Risk Forum. The only thing is we have this series that was published with a long follow-up from IDEO team. So for the how Carlos said, with low functional patients, but for young patients, the only thing is that we don't have one series with a long follow-up for the moment. We have the 11 years follow-up from Jean-Michel Cognier, I think, Lorenzo, if I'm not wrong.
No.
But for the moment, we are waiting from a long follow-up series for young patients, because we are generalizing here this technique for young patients, and that is the point. We are every time I perform this technique, I am wondering if I am really choosing the right technique for a young patient. IDEO, what do you think about? Could you share your opinion, please? Because you have the experience for young patients.
Yeah.
What would you do in your team?
So unfortunately, we have no such a. So this is a 15 years old, so extreme young patient. We have no cases such a young patient, but I'm very interested in the long follow-up outcome. I'm very interested in the outcome. So I want to introduce you some tips for this procedure. First is I totally agree with Lorenzo's opinion. The dorsal segment is very technical demand. So we want to preserve the small tip for the dorsal fragment. So every cases we do our Boral Porter. We use Boral Porter with ultrasound assisted Boral Porter. I recommend. And we have one cases. The big segment remains, so impingement. Lorenzo was introduced. So we performed the reoperation for that case. After that, the impingement was recovered. So now good outcome. And the second tips is we experienced 42-year-old women with scleroderma. After that, pain relief was amazing, completely amazing. But the range of motion was not so good because of scleroderma. So we have to pay attention to the scleroderma or something illness. So that's all. Thank you.
Thank you, IDEO. I just would like to have the opinion of others. For example, Fabio, Martin, other teams about this technique that we are doing more and more here. Maybe Martin or Fabio, if you all.
Maybe may I pose a question to Lucian? Good morning.
Who is talking?
Vitale.
Good morning. Good morning, everybody. A question to Lucian. First of all, thank you for the case. It's very interesting, as it's it's quite unusual in my experience. A so young teenager with such a evaluated disease. And I totally agree with you with the importance of speak with the patient, with the family of the patient about the different option and most important of the concept of non-burning bridges behind us while doing this procedure. So this is a question about the follow-up of this patient. Do you have a scheduled follow-up? You see the patient just 1 year after if she's painful, or you are a more scheduled follow-up to see and prevent eventually a bad evolution of this case, eventually a bad evolution.
Okay, thank you. I saw her at 1 month, okay, 2 months, and I will see her after the summer, okay, to see how it evolves. And as she a teenager and it's quite a new operation, I will try to follow up better, a smaller,
once a year maybe,
a shorter interval follow up. But if she was older, I think I would see her like every 6 months. That's
and
it.
Another question, and then as I think you have, as you said before, you and Lorenzo, it's very important to have a B and a C plan in this kind of patient. Do you think that eventually a B plan could be a PRC, and in the future, with eventually a prosthesis of the lunate, or you would go, or you think it's a partial arthrodesis? It could be a solution after that. In the future.
I need to see what is the problem in the future, because we need to solve the problem that will she will
present. She will show.
If she will have a ruined capitate, then my options are really low. If she shows us only an adapting carpus and radius without pain, for me radiology is not important. So it depends on how it will be. We don't know. We really don't know.
Okay.
We don't follow up. So I don't really know. But we didn't do anything big, you know. So we have a lot of possibilities in the future to readdress.
I agree with you. I totally agree with you. It's a it's a very good
Thank you very
choice.
much.
Thank you.
Martin, you have a lot of experience.
Yes.
So
yes, thank you, and thank you for this invitation. Sorry, I connect a little late because very early in Argentina on Saturday, and I'm old man. Congratulations for the case. I didn't see completed, but I give my opinion and spirit, my humble opinion. I treated many cases of Kienboch disease. Of course, we are talking about the salvage procedures. In all this case, we are treating in the yellow stage of the illness. So I didn't know if Gustavo comment about the Argentina experience. We have in Argentina a famous Hanser that he passed away. His name was Blanco, and he published many years ago about the 19th follow-up after lunarectomy and how the carpal adapt to this situation. And I have 5 cases with the follow-up. I think that the most is 15 years, and the patient no have problem. Of course, in my cases, all the patients are almost 30 or 40, not younger that you treat, Lucian, but the carpal adapt to this situation of when you take only the lunarectomy. And of course, we saw an migration of the capitate to the proximal, but the patient no have pains. And for my surprise, it was incredible how keep maintain a very good range of motion that allowed to this patient to do the daily activities. So probably, of course, I did another operation. I learned with Professor Fernandez, the Graner operation. I don't know if you know about it. This is enlarge the capitate, but it's of course by open approach. You have to take the lunarect away, and you make a cut of the capitate and make a bone graft and put the capitate in the proximal carpal row to maintain. But all these procedures are salvage procedures. I agree with you that probably the arthroscopy approach, and if you respect the soft tissue and especially the sling, dorsal sling of disc and capsule and the volar, probably I really don't know what happen in the future, but probably it's a good election, a streaming election for these late stages. And this is my opinion, but don't take afraid to take away the lunarectomy, because my experience in a little small size of patient is it doesn't happen. The patient, the carpal adapt to this situation, and the patient maintain a good range of motion without pain. I published many years ago in the Argentina Hand Society these 5 cases. I know, Gustavo, if you comment about our experience in Argentina with Roque Blanco.
Martin, we
Yes,
yes,
Martin, we talked about that a few minutes ago. Yeah. About the papers. Biagio showed the paper of Roque Blanco.
Okay, so sorry, I didn't.
No, it's okay. It's okay. I would like to ask to Fabio Tandioi. Fabio, what is your behavior in a case like this, in which we are a little bit concerned about the age of the patient? Do you use this technique of lunate excision, or you prefer another alternative?
Gustavo, I don't have a bigger experience in this type of disease. I remember when you visit you 2 years ago, we have a good discussion about the lunate excision. Remember, I see some papers, but I don't have a big experience in this type of problems.
Okay. Thank you, Fabio. So because of the time, I see that MARRIDI is raising the hand. So I think it will be the last comment, because we are not going to have time for next case. So MARRIDI, how are you? Do you want to?
Yes, I want to actually make a comment. Kienboch disease usually presents to me at the clinic late. I rarely see cases that come with stage 1 or stage 2. Most of my cases are already stage 3 and beyond. And to be honest, whether I do PRC or Kienboch or scaphoid capitate fusion, we are losing something. We are paying a price for the pain relief, whether it's range of motion or weakness. And these patients are in their 20s and they're high demand, and many of them are manual workers. So they are not very happy with the outcomes of the surgery, regardless of what we are doing. And I was thinking, what is actually a contraindication for the surgery, for the lunate excision alone that we are proposing? And in my mind, I'm thinking of it in the future, having it as the go-to surgery as a salvage procedure. And if it works alone, it's perfect. If it needs some help in the future, whether to continue as a scaphoid capitate fusion or a PRC, then that's it. But it's not a proposition, but this is what I'm thinking. Do you think there's a hard contraindication to doing this for every salvage lunate you have, besides like severe arthritis? I'm thinking about contraindications, and I can't find a real big contraindication besides arthritis. And if that's the case, maybe this should be our go-to procedure as in salvage case.
I agree. Only arthritis, actually.
Yes, and maybe so. Then this will be our go-to surgery in salvage. Otherwise, and if it works, fine. If it doesn't work, you can continue to whatever other bridge we didn't burn, as you said before.
Or if you have a very significant scaphoid flexion with a starting pain in the radial column, that means probably you're gonna end up with arthritis in a few years. So probably also this could be a point of alert. But if not, I agree. I think it's a good first step. And it might be the last step, or if it's not, then you start over. It's not a problem.
Well, thank you very much for working so hard on putting the surgery as an option for us, but it's looking as a very good option so far.
Okay, thank you. So, well, it has been a very interesting case. Thank you very much, Biagio and
Thank you,
Luciano, for bringing it to us. So we think that resecting the lunate is not crazy. It may seem like a fearful decision in patients of this age, but we know that we do not burn bridges for the future, as Lucian said, and we can do a scaffold capitate, for example, fusion in the future if necessary. So it's very important to follow the patients. We know that resecting the lunate by arthroscopy is better than with open surgery because we preserve the ligaments, especially the radioscaphocapitate capitate and the dorsal radiocarpal ligament. And as Lorenzo said, we can preserve some little bone chips to avoid damage of the damage of these ligaments. And it's important to check under image intensifier in the surgery with some test if we are having volar subluxation or dorsal or ulnar translocation of the carpal, so we can see the ligament stability. So we have to move to the next case. So I would like to ask to
actually, it is our case here from Paris. We prepared it with Tadeusz, and since Tadeusz has some internet issues, I will present it with him. Please, thank you, Gustavo. Biagio, could you stop sharing your screen, please? So I will share mine.
Okay, okay.
So this is the case. Sorry, this is the case we prepared with Tadeusz and with Logan, our fellows here. So it is a painful chronic wrist clunck. We present this very young patient, 30 years old patient. He's right-handed. He's a sales assistant. He used to be a tennis player, teacher, and he had a right wrist trauma, high energy trauma, 3 years before coming at the consultation. And he comes for a chronic painful clunck. At the clinical assessment, he has an ulnar wrist pain, especially tenderness on the lunotriquetral space. The foveal sign is negative. The ballotment test is negative. And as you can see here, there is a stiffness, inflection extension, and a huge reduction of the grip strength. So I can show you this. We can see and we can hear this huge clunck. I don't know if you can hear it. So the first question we will develop now is what are, when we have such a patient coming to the consultation, what are the possible main diagnoses for painful wrist clunck? I will ask Tadeusz, please, to comment because he read some papers before to prepare this. Tadeusz?
Yes, basically the question we can ask, like more simple, is where the instability is, and the most proposed classification is division into carpal instability non-dissociative. So basically, this is a situation when the whole proximal row is acting together. So, and then it's instability happens in radiocarpal or mid-carpal joint, or carpal instability dissociative, what means basically that there is some insufficiency between SL or LT or other, but basically it's something in between, something happens in proximal row. It's another option is instability complex, what means there is combination of these two, and usually it happens after some attempt to make a perilunate injury. It does not mean it is always after complete perilunate injury, and axial instability as so this is, and we can go on. So basically we need to answer where it's happening, if it's something around the lunate on both sides, or it's the whole proximal row is acting.
Okay. So for the clunky wrist like this, sometimes you think about mid-carpal instability. Tadeusz? For the
Yes.
clunck?
Well, oh yeah, what is so yes, we should take in mind, but what is against mid-carpal instability, that is LT plays and SL plays were painful, what means that it's more probable from physical examination, it's more probable that the clunking happens in around the lunate. But yes, we have to bear this in mind also.
Thank you, Tadeusz. So if there is no comment from the panelists, I think we can go on. So we decided for this patient to ask for bilateral comparative and dynamic X-rays. You have the right wrist on the top, and we have the comparative X-rays below. So if someone would like to comment on the X-rays, maybe I can see Zé, if you would like to comment, please.
Yes. So the top 4 X-rays are essentially the right wrist affected X-rays. You could see the PA views as well as the lateral views. The PA view on the far right, I assume that it's the sort of the stress view, but you could see that there is a scaphoid ring sign indicating that possible that the scaphoid is flexed. The lunate, we could see that is either flexed or extended. The gillular lines generally looks quite well preserved. On a lateral view of the X-ray, which is the top second from the right X-ray, you could see that the lunate is slightly flexed. Ideally, you will want to actually measure the scapholunate angle. In this case, it looked like it's possible that the scapholunate angle is slightly more than 60 degrees. And the yeah, so I would think that in the clunking wrist with these X-rays, I will be thinking of either is it mid-carpal sort of instability where the entire proximal carpal row is flexed. And in this case, you can see that the lunate is slightly flexed a little bit. So that is a possibility. Or is it some form of a scapholunate or lunar triquetral or sort of a floating lunate type of differential diagnosis? Okay. So probably you want to do an MRI to further assess this, or a CT scan.
Thank you, Zé. So actually, we did a CT scan and MRI. I'm very sorry because it is an old case. So the patient kept his MRI, and I could only have this CT scan pictures. And what I can say, Zé, is that the MRI showed complete scapholunate tear at the time. And it was not informative about the dorsal intercarpal ligament. We asked for the patient to have another MRI or Arthroscopic scan. He couldn't because of economic issue. So we have this CT scan and have this MRI.
Yeah. So for patients with scapholunate tear, I mean, we would assume that if there is an isolated scapholunate ligament injury, the scaphoid will be flexed, the lunate will be extended. In this case, the lunate is in a neutral position, and also the capital lunate angle also look relatively well preserved. In this case, if the scaphoid is flexed, but the lunate is neutral, I wouldn't think that it is a proximal row sort of a CIND injury. So I wouldn't think that it's a mid-carpal type of instability. But I think at the end of the day, if the patient is symptomatic, there's a clunck, I'll be thinking of either mid-carpal or sort of an intercarpal instability. I would do an arthroscopic assessment as it is like the gold standard in assessing the ligaments.
Thank you, Zhe, for your comment. Is there any other comments from the panelists, please?
Alam, can I only one comment? I think that Gustavo, the last webinar, spoke about the importance to see also the behavior of the lunate in the lateral ulnar direction, and it's very important. I think it's very important to see if there is an ulnar translation of the lunate, and sometimes it's a very important sign. We look a lot on the space between scaphoid and lunate, and on flexion extension of the scaphoid and the lunate, but a lot of us miss the evaluation of the ulnar translation of the lunate, and it's very important because if the ligaments are torn around the lunate, it will go ulnar, and we can see it, I think, in the right wrist in the X-rays, and it's something that we need to look about. I only wanted to stress that, and Gustavo spoke about it the last time. It's very important.
Yes, thank you.
Maybe another quick comment also, if I can, on the radiological assessment. More and more, in my experience, when I have clunck type presentation, patient coming for a wrist clunck, any type, it's a dynamic problem, because that if you do static exam, you're not going to find much, because the clunck is revealing after some kind of movement. So now even more, I tend to ask the radiologist to do movies just like we do in the OR. They do video of continuous X-ray, and then 100% of the time you can see something clunking into the video actually, and most of the time you see like a lunate clunck revealing a LT instability or a proximal row instability or so. But I think dynamic X-rays like this are interesting, but they do not always bring the dynamic per se movement of the clunck, and videos, X-ray videos, continuous X-ray are really interesting, and usually they gave you the answer. But you have to have a radiologist friend to accept to do continuous X-ray video.
Thank you, Lorenzo, for your comment. Do any panelists or someone have any experience with CT scan or dynamic MRI? Because I know we don't have the opportunity the chance to have it here in our practice, but I know, for example, Bülent, who is not connected today, has very, very nice videos of those dynamic advanced imaging. Lucien?
Yes. Yeah, we do a dynamic MRI quite frequently. We have a very young and interested radiologist that likes to experiment them, and also an ultrasound is very easy to put on and to see the movement of the carpal row during dynamic movements. It's also very easy. We all have it in the office today, and it's also very an important tool if you know how to use it.
Thank you, Lucien, for your comment. Any other comments for the panelists?
Yes, I want to, Alan, I want to add a comment. Yes. I don't have experience here in Argentina, but the CT scan 4D is another very important tools that you can make an examination with precise, and you can measure, including the distance between the, for example, in the scaphoid, lunate, and troquitul, and what happened with this ligament during the underload. So we don't have still yet in Argentina this tool, but I think it's very important, and in the next year maybe increase the use of the 4 CT scan.
I think we are going to ask with Lorenzo, our radiologist here, if we can have it as well, Lorenzo. So for the moment, we couldn't do it, so we went for the arthroscopic evaluation, traditional arthroscopic evaluation. So as we can see here, it was very interesting at the radiocarpal assessment that the cartilage were perfect, as we can see above. And we found complete dorsal scapholunate ligament tears, DCSS, a huge synovitis. We perform an extensive debridement to refresh all the capsular ligamentous chronic lesions. With the scope in the 3-4, we found lunotriquetral ligament avulsion. And at the midcarpal assessment, we confirmed gross double instability, one on the scapholunate, as we can see on the left, and also one on the lunotriquetral space, with which was reducible, as we can see here. So we concluded to a floating lunate, chronic floating lunate pattern in this patient. We decided intraoperatively to perform a very simple technique, double arthroscopic dorsal capsular ligamentous repair. Here is the view of the passage of the needles through the 3-4 portals through the scapholunate space. This is the view of the passage of the needles through the 6R portal. They take radial ulnar to radial direction. Here is the passage of the suture, the view of the suture. It is very, as usually, the midcarpal joints. And here are not really the picture of the case I present, but it is another case which is very similar because I didn't have the pictures. So we can see the passage of the needles for the lunotriquetral suture. It's very simple. We can see below the 2 needles taken ulnar to radial direction, and we can see how we retrieved the suture from the midcarpal, and we perform the note for the lunotriquetral space instability. Here is the first note fixation for especially the lunotriquetral instability, and we can see, I hope the video is visible, we can see after proximal distal traction the good reduction of the step off above. So at the final follow-up, we were surprised to have a good outcome in this patient with a good range of motion. He recovered some strength, as we can see here. So it was satisfactory for this patient, and especially for the instability. We can remember this huge clunck, and after surgery, there is no clunck, no residual instability, no residual pain, even if we check the patient now every year. He's very happy with his simple technique, mini-invasive technique. So I would like to summarize. Floating lunate is a double scapholunate and lunotriquetral instability. It is always associated with severe ligamentous lesions. So diagnosis can be difficult, but we have some specific symptoms: the clunck, the associated scapholunate, lunotriquetral pain, and all this dynamic imaging. The patient always presents with chronic wrist pain and wrist disability. It was first described in 1990 by Pin as a concomitant complete rupture of scapholunate and lunotriquetral ligament with no perilunate dislocation. And it was described first with intact extrinsic ligaments or only partially injured. And it was considered as a precursor of Mayfield stage 3 perilunate dislocation. So Badia in 2009 gave first the name of floating lunate because the lunate was in a neutral position. Corella in 2015 described the arthroscopic rocking shear sign here with a floating lunate. So we know that the capsulodesis effect is capsule to ligament suture. It's interesting and efficient on chronic scapholunate instability. And we have also some interesting papers that are published that the same technique applied to isolated lunotriquetral instability showed satisfactory results. So we applied this suture to both scapholunate and lunotriquetral intervals, as we can see here. And we included all the patients who had the floated lunate diagnosed, confirmed at the arthroscopic evaluation. And all the patients with degenerative cartilaginous lesion were excluded. Here are our updated series here. It's 16 patients. And what we can see is that the pre-op imaging we use are not specific, especially for the MRI. They show scapholunate, lunotriquetral tears in some cases, and it really depends on the quality of the imaging. And unfortunately, we can't do sometimes more and more exams because of economical issues. So for this updated series, the arthroscopy found all the time gross instability in both scapholunate and lunotriquetral spaces. And after double ADTRR, the results are quite good, especially the functional results. And there is no residual instability with this simple technique in most of the majority of the patients. So we know that scapholunate and lunotriquetral complex stability is assured by, especially now, the extrinsic ligaments. So that is why we use the capsulodesis effect. For the lunotriquetral ligament, traditionally, we think that the palmar part has biomechanically the main role. But we, as I told before, the dorsal capsulodesis is efficient, probably because we tension the dorsal intercarpal ligaments. So the already described technique, PIN technique, there is a partial refusion that was described for lunotriquetral instability. All the partial refusion are lead to stiffness and are invasive. We have the Badia technique, the arthroscopic debridement and pinning for floating lunate. So we have some concern about the long-term efficiency on the carpal instability. And we have also the correlate technique. It's a very interesting technique, the arthroscopic technique, but it is technically demanding for this kind of arthroscopic ligamentopathy. So Bülent, who he's not connected today, he published his 42 patient series. And Tadeusz, could you comment, please, the series of Bülent?
Yes, this is a very nice paper, not only because it promotes also technique that was used by our team. They included 42 patients. What is interesting in the group of the patients, more or less half are doing kind of manual work, and 6 of them are heavy manual laborers. So, and follow-up was minimum 2 years after surgery. The technique is exactly the same as you see on the pictures. So I don't comment on this. And the results are quite, I think, in my opinion, quite good. So this is 10 patients only have fair results and even better, and the rest even better.
What are the, do you remember, Tadeusz, the fair results? They have to be reoperated? No?
Basically, no. They left the patients, or they don't mention about the reoperation. What is also important that they mention no major complications. So this was like, so I think they follow just the patients because it was not mentioned in the.
So we will ask Bülent. Thank you, Tadeusz. So we have also for the therapeutic option, we have also some interesting, more recent techniques that could be a good option for this floating lunate pattern. Of course, the supracapsulopathy of Gustavo Mantovani, which retention the dorsal intercarpal ligament. And since we know, we will maybe talk about this with Gustavo Gomez, since we know that the DIC have insertion of the trikic from this technique could be an interesting option here. And recently, René Jorquera described also the arthroscopic or peludinate instability reconstruction. And I think this technique could be also a good option for a second look surgery if the less invasive techniques are not efficient. So my take-home message here would be that the ADCLR, when it is applied on both gefluinate and lunotriquetral intervals, is simple, not invasive. It avoids dissection, allows a precise diagnosis, especially when we can't have a precise imaging before. It showed preliminary good results, and it could be an alternative. We need a larger series with a longer follow-up. And thank you all for your attention. And I think we can, before the discussion, I will ask just Tadeusz to say 2 words about the non-dissociative clunky wrist because you read and reviewed the paper. Please, Tadeusz.
Yeah, just it's quite as we see, it's quite classical paper, 2008. Just to mention about when we were at the very beginning, we were trying to assess if it's more like the problem in between proximal row or it's somewhere else. So this is there are many options of treating them and diagnosing no dissociative clunking wrist. I'm not going to cover it. One remark that general idea that might be interesting to our work in this case is that usually these instabilities overlap. So this means that yes, we diagnose insufficiency about lunate, like in LT space and SL space, but usually there is some additional insufficiency in another level, because this happens in non-dissociative clunking wrist, and probably this is, we can assume it, and that is always combination of other insufficiency. That's only short comment because I think I don't want to take more time on this.
Thank you, Tadeusz. I will start. Okay. Gustavo.
Okay. Thank you, Lam. It was a very interesting case. Thank you, Tadeusz, for your comments. So, Alam, since you and Lorenzo are nowadays the masters of the capsulodesis, I want to ask you two guys if nowadays you give some place to palmar capsulodesis in both scapholunate or lunotriquetral joint. If so, in what cases will it be? And or if you think that just with dorsal plicature of the dorsal portion of the scapholunate and the lunotriquetral ligaments is enough.
I would just say for this. Sorry, Lorenzo, but I will just say that I never.
It's a question for both of you.
Yes, because we are doing, I think, the same.
Both.
Yes, we do the same. It's the same school. There is a huge question actually around the biomechanical role of all the palmar structures. And we don't believe really that, in my opinion, for the moment, we don't have enough level of evidence of the role of the palmar ligaments, especially the FCT. And so in our hands, the all dorsal retentioning structures, especially the dorsal intercarpal ligaments, work, and it depends. We choose the retentioning technique, the simple ADCLR, or the modified technique, or the DIC retentioning technique. We increase the retentioning of the dorsal ligamentous structures according to the EWAS classification. And we follow the patients clinically with the imaging, but especially clinically, there is the pain and the instability disappears. And for the moment, I don't reconstruct or retention or repair the capsule, the palmar structures. Lorenzo, sorry.
I agree totally, with just a little precision. For scapholinate tear, I never do volar repair, because usually we now develop with the France technique, South America technique. Now we have a lot of tools, arthroscopic tools to, as said, Alam, to retain dorsal structures, even in a super stronger way. And I think with this technique, we can have very satisfying stabilization of the SL joint. For LT, we know from some biomechanical studies that the volar part of the LT might be a little more important than the volar SL portion, which we know is not so useful. But for LT, sometimes I have an indication for volar repair adding to the dorsal one. I always start with the dorsal repair for LT in the same technique that just presented Alain, like a dorsal LT capsulodesis, for capsulo-ligamentous repair. And then I go mid-carpal to check if I have good reduction, especially in the volar part of the LT space. If I do, then I stop. If I don't, and if I still have some instability or volar widening of the LT space, then I do the technique that I think that's Jean-Ragnar Haugschweg from Sweden that presented this. It's like a replication of the ulnotriquetral ligament, and that I do from the radiocarpal joint. It's quite simple to do, but it's the only trick is not to catch the ulnar vascular and vascular and nervous bundle. But from a 6U portal, you can enter a needle with a suture inside and grab all the volar capsule on the ulnar aspect. So you grab all the ulnotriquetral ligament, and you just tie your suture around it to do application of the ulnotriquetral ligament, and this will bring down your triquetrum to the level of the lunate and help stabilize it on the volar aspect of the joint. And this is something that I sometimes do, but that's it.
For just a comment, Gustavo,
thank you,
Lorenzo. Thank you, Lorenzo. I totally agree with Lorenzo. The only thing is the one comment for the ADCLR in my hands. In the huge instabilities, I find it's much more efficient when we perform this intraoperative traction. There is all the time a very good reduction of the lunotriquetral space. That is why I think the DIC is important. It has a huge role in stabilization of the lunotriquetral space, much more than the lunotriquetral interosseous ligament itself. And Gustavo, you had your nice dissection and picture about the DIC turning around the triquetrum. So that was my comment.
Gustavo, if I can add something, I have experience with the lunocarpal shrinkage with the suture that Lorenzo spoke about it. So when I have a lunotriquetral instability, this is my first choice treatment, a suturing of the ulnocarpal ligaments, okay, from the 6U portal, okay. But when I have a floating lunate, I do like Lorenzo and Alam said, I try to do a dorsal capsulodesis, and then if I feel that the stability of the the triquetrum is not perfect, then I use also this suturing. So it's quite good. But Lorenzo, I think that Zay described it.
I'd say, okay, sorry.
Be careful, Lorenzo. We have many Italians
Yeah, be
here.
careful, you know.
Sorry.
Okay.
Don't mess.
Okay, Hideo, Se, Martin, Fabio. I don't want to. I don't know if anybody
You don't
has
have any question in the chat?
No, no question on the chat.
May I ask a question?
Oh, I'm
sorry.
Yeah.
I always have
we have
a lot of
Fabio
questions.
after. Zay and Fabio.
Okay. No, okay. So I've always wondered, maybe I didn't read a lot enough, but floating lunate versus a perilunate injury that is non-dislocated, is it a spectrum or is it an isolated pathology? Because I was just thinking, a floating lunate, you've got a scapholunate injury, you've got a lunotriquetral injury. Could it be a perilunate non-dislocated type of injury? And if it's so, do you often check the radioscaphocapitate ligament, the long radiolunate ligaments? Do you often check the DIC ligament often, in addition to the scapholunate and the lunotriquetral interossei? How often do you have RSC ligament injuries that you have to repair, for example, or DRC ligaments?
I think that was also the point raised by Gustavo last time with the association of combined lesion. Actually, I think wrist ligamentous lesion, the spectrum is very complex actually, and it's hard to categorize everything into, small categories with, small diagnosis. So it's an isolated SL tear, it's an isolated LT tear, it's an isolated DIC. I think usually the trauma gives a multitude of moderate to severe form of ligament tear, and I think one of the goals of arthroscopy to do a complete assessment every time for every cases. I mean, if you go for an isolated SL tear, this shouldn't stop you to check all the ligaments with arthroscopy, because sometimes, especially if you have some doubt on the X-ray with a slight ulnar translocation or so, you might find some volar radiocarpal ligament problem. You might find some floating lunate or some beginning floating lunate, because I mean there's a lot of possibilities, and I think you should check for everything. But some floating lunate are an aftermath of perilunate non-dislocated, and some floating lunate are SL tear that also developed an LT tear for overuse reasons afterwards. So it's not always easy to have a complete spectrum of the lesion.
It was the purpose of this case. It is we were very surprised when we entered the wrist and we checked everything. You check you have specifically, and intraoperatively I decided to do this very simple technique after a good debridement. I think in the chronic cases, refreshing the lesions is very important. Especially on the dorsal side, when you have the DCSS, we are with us every day at the OR. You can see how long the time it takes to refresh the lesions in the chronic cases. And it was to demonstrate that we need to give the chance to the patients before a big arthroscopy, ligamentoplasty. After I moved to Gustavo Gomez options that are my favorite, of course, here, Gustavo. But the moral of this case was, the patient was doing well. He was stabilized. We check him every year now, and it was a very simple technique. So give a chance to the patient and to the nature is stronger than everyone as Christophe tells us all the time.
Fabio, you wanted to say something?
Yes, I believe now the extrinsic ligaments are very important. Every day, extrinsic ligaments are growing in the importance. DIC for me is very important. I recommend our people who start to do arthroscopy learn to test the DIC ligament in the middle carpal joint. because more of the treatment include this ligament for the for example, mid-carpal instability or scapholunate ligament or lunotrochlear ligament. How this technique.
Hello, may I ask a question? I think
Yes.
this technique is good in acute presentation in which there is still remnant of scapholunate and lunotrochlear ligament. So do you have any experience in late presentation? The patient presented to you very late. There is no more remnant of scapholunate and lunotrochlear ligament. How do you have any experience? And if have, how you do in that kind of case?
I didn't hear you well. Has anybody hear him?
Mark, could you please?
Can you repeat here?
Yes.
You can hear me?
Yeah, better now.
How about in the late presentation of case in which there are no remnants of scapholunate ligament or lunotrochlear ligament? Do you have any experience in that kind of case? I think in the acute presentation, maybe we can use arthroscopic repair scapholunate and lunotrochlear ligament. But how about in the chronic case or very late presentation in which no more SL and remnants of SL and LC ligament? Do you have any experience?
In those cases, we try to adapt our surgery. It is important to have the dorsal capsule structures that are good quality to perform this technique. Sometimes we use anchors if there is a kind of ball scaphoid and we don't have remnant on the scaphoid side. And we need anyway to keep in mind that if we can't use this simple arthroscopic dorsal capsule ligamentous repair, that we have a second option, other option of reconstructions. But it is rare, actually.
You don't use ankle suture or maybe K-wire supplement?
If there is no remnant, ligamentous remnant on the bones, we can use anchors that anchors on the scaphoid, and we have this technique using anchors, which was published with Caratala, I think.
Yeah, it's Vicente Caratala technique, and it seems to be pretty useful when you have an avulsion of the ligament and you don't have, as Alam said, you don't have any remnant attached to the bone.
It's really efficient in acute cases when you want to reattach the ligament to the bone. Yeah.
But actually,
exactly. It's very important that it's an acute case.
In theory, even if you don't have, in theory, but I'm a little provocative, even if you have no ligamentous remnants, this technique should work, because it's not I told capsule to ligament because it is the theory, but the most important is to have a capsular and the extrinsic ligaments, good quality extrinsic ligaments and the capsule, because we think more and more that we are retentioning the dorsal extrinsic structures. Mort.
Yeah, actually, the Caratala technique was described for acute cases only, and yeah. I tried it in some chronic cases, and it's very difficult because you don't have a quality tissue to grab, so it fails. No. It doesn't work. Okay, so it's only for really acute cases. But Pedro Delgado has another technique in which he puts two anchors, one on the lunate, one on the scaphoid in mid-carpal, and takes the capsule and does a capsuloplasty with anchors in arthroscopy, which is maybe better when you don't have a good quality of good tissue to attach. But the cataract technique is only in acute patients.
Okay, we are on time, Alam.
Yes, I think we can.
Gustavo, Gustavo,
Martin,
of course, Martin.
Yes, I make a last question for the panel. How you evaluate the scapholunate ligament or lunar tricutal ligament? I mean that, do you only use the dorsal approach to the mid-carpal space to evaluate, or you think that probably in the future we have to start to make a volar portrait to evaluate the dorsal part? This is a question that you can ask in your spirit, because for me, and especially the the meaning to the young hand surgeon that start with arthroscopy, the difficulty is to evaluate, and I have the same inter-observer observation about the tears of the scapholunate of the lunar tricutal ligament. So for me, it's very difficult, and I try to learn to my fellows the experience. They make more than 4,000 re-arthroscopy during the last 20 years. And it's difficult sometimes to quantify the extension, as you say, Gustavo, in the last meeting, the extension of the lesion. So the question is, do you think that in the future we can just start to evaluate the complex of the scapholunate or the lunar tricutor with using other portals or using volar portal to see in front? This is the question that I want to ask to the panels and listen to comment. What do you think about it?
Actually,
well, I know.
Go.
No, it's okay, Alam.
No, it's okay.
Ahead,
Please, Gustavo.
Because...
Yes.
No, I was going to say that I never wondered that. So I have no experience to evaluating the dorsal scapholunate complex by volar portals. But please, Alam.
No, it was actually the same, because just with the first, we evaluate the quality of the structures. If there are, we can do some effective suture on them. And the other thing, we have the EWAS, the instability of the mid-carpal assessment, which is very important for the making decision, intraoperative making decision. And from just the dorsal, we can evaluate all our dorsal structures and the instability. So it is enough, in my opinion, for me, actually, at least.
I think it's very important to resect all the synovitis that we have at the dorsal aspect of the mid-carpal joint when we are accessing scapholunate instability, because sometimes we are not able to see the dorsal intercarpal ligament because it's completely under synovitis. So I think that the first steps in our arthroscopy should be the resection of this synovitis, so we can have a nice view of the dorsal intercarpal ligament, and we can evaluate the attachment of these secondary stabilizers, which is very important, on the dorsal aspect and radial aspect of the scaphoid and the dorsal aspect of the lunate. And I think that perhaps if we do a very nice debridement of the dorsal recess or in the mid-carpal joint, we can have a nice evaluation and a nice access to those secondary stabilizers.
Debridement is very important.
Yeah. So now we are on time.
I think.
Alam, you should close.
Oh, thank you everyone for joining once again. I don't know if in the guys of LATAM who are on holidays, in Europe we are on holidays, we are lucky. So thank you once again everyone for joining. The next session is on September 2, and I hope you will be to see you on September. It will be, I think, Gustavo case, and we will have a case from Santiago de Chile. Thank you once again, and have a nice summer and nice weekend. Bye-bye.
Thank you.
Thank
you.
you.
Bye-bye.
Ciao.
Thank you.
Bye.
Bye.
Bye-bye.
Thank you. Bye-bye.
Bye. Thank you.